used pre-operatively and post-operatively in surgeries here in the hospital. So I've got a little bit of information. You guys probably know more than I do. So just wanted to start off with dual antiplatelet therapy. So this is commonly when aspirin is in combination with something such as clopidogrel, or you've also got the anticaogs, which you guys might know it as Brilinta. So these are used in combination pretty commonly post-PCI, so if they've had a stent put in. So basically it's just going to give that extra push. So you've got your aspirin, you've got your clopidogrel, it's just going to provide a little bit more anticoagulation. So how these ones work, they work on the antiplatelets. So they do work a little bit differently to things like Clexane, which work on the fibrin in the blood. So they work on different components in the blood. So just to help, this is what I use for my cardiac patients. So some of these terminologies are a little bit basic. So I like to explain it to them as their blood sticking together to form clots. So when you've been prescribed these medications, if they've had a heart attack or if they've had coronary bypass surgery, usually aspirin will be for life depending on what condition, and post-op though usually it's only for about 6 weeks, and clopidogrel is usually the first 6 to 12 months post PCI or a CABG. Commonly asked questions, so these again are for questions that I would have up for patients. So what to do if you stop taking medicines, never stop taking medicines without consulting the doctor first. So that's what we like to tell the patients when they come in here as well. If they're on aspirin, that they continue on with aspirin unless it's been stopped by their doctor. So what are the side effects? So bruising easily, longer bleeding time, can occasionally get some small bleeds when you're brushing your teeth and things. They're all pretty common side effects that I like to warn my patients about. If there's blood in the urine or in the stools, I like to tell them that that's not a common side effect and that they would need to review that with the doctor. And I've also got, when should you take these medicines? Best at the same time every day. With aspirin, best on a full tummy because it can give you that GI upset. And also, why are these medicines used together? So more effective at decreasing the risk of cardiovascular events in higher risk patients. So these are our anticoagulants now. So a little bit different to the antiplatelets. They just work on a different cascade in the bleeding. So we've got medications that stop the clotting signals. So these are for patients that are at risk of blood clots, heart attacks, post-surgeries as well. So patients that are at higher risk. So sometimes if they're elderly patients, if they've got active infection, cancers and things, all puts them at higher risk of bleeding, of a VTE. So medicines can be also used in conditions such as atrial fibrillation. So it's always important as well to clarify if the patient came in on something such as Xarelto or Eliquis, because they will need to be using that post-surgery as well. So they'll also be using it at the dose that they came in on. So provided, so for example, if the patient comes in and they've finished their surgery, they're going to be on the if they're on 5 milligrams for their AF before they came in, but the dose for post-surgery is usually 2.5 milligrams BD. You're going to go with that 5 milligrams because it's treating another condition as well as it's treating that VTE prophylaxis as well. So again, same sort of side effects. You've got your bruising, your nose bleeds, but we like to tell them if you're vomiting up things that it's like dark, tarry coffee grounds, that's something more serious and it could mean that there's an internal bleed going on. So that's something we would also refer to the doctor for. So there's just a couple of examples for you guys. So anticoagulants, so that's your things like warfarin. So it's also important to note there are 2 different types of warfarin. So you've got your Maravan and you've got your Coumadin. They're not interchangeable. So if the patient comes in on one brand of Maravan, so you're not going to change them, then the brands aren't interchangeable. So it's important that they stay on that brand. You've got your Pradaxa, you've got your Clexanes, Heparins, Xareltos, Eliquis. I just like to use that slide and show my patients like the tablets that they might be taking, because they'll often not really realise what boxes they are, but then if they look at a tablet they'll be like, oh yeah, I do take that tablet. So commonly asked questions about anticoagulants, how long will they be on the medicines for? Usually it depends on the condition, again, so post-surgeries, depending if they've had a hip replacement or a knee replacement. So knee replacements is usually 10 to 14 days, and if it's a hip replacement it might be a little bit longer, for about 30 days. but conditions such as atrial fibrillation, it'll be a lifelong. So, difference between antiplatelets and anticoagulants, so they just work on the different cascades like I said before. I've got your beta blockers in here, so they're just working to slow down heart rate and reduce the conduction of the heart as well, so it's just going to help with blood pressure. It also helps in other conditions such as atrial fibrillation again and arrhythmias. So it can also be used in migraines, so commonly propranolol is used in migraines. Usually they're not first line for blood pressure, they're usually after an ACE inhibitor or an AT2 blocker. So benefits of this medicine: reducing heart rate, and it doesn't actually affect the kidneys. So most of the drugs, anticoagulants and things, they do affect the kidneys. So with this one, it's not usually the first one stopped in hospital. So if a patient is hypotensive, you'd be looking at getting rid of something like the ACE inhibitors first, which could potentially affect their renal function. And commonly, because they are on other medications like NSAIDs and things like that, that's also affecting the renal function. So with this one, you're going to leave that on there because it's not affecting the kidneys, and it's also being used for other conditions. So we don't want to disrupt that AF or anything like that. So typically, we don't withhold this one. Unless, of course, the doctor has specified. So anticoagulants and antiplatelets that are ceased prior to surgery. Now I know you guys don't have too much to do with pre-surgery, but I just wanted to include here like a little diagram. So it's just got monitoring of warfarin. So warfarin does have a longer half-life, so it does sometimes require a bridging therapy when going back onto it post-surgery. So it can be commenced within 12 to 24 hours post-surgery, but it won't actually have full effect for around 5 days. So that's why you'd be using that clexane first. So you can use the clexane and the warfarin for those bridging, just so it's giving you that anticoagulation in the gap there. So enoxaparin is usually used first line in this. So using the clexane when using the warfarin to just bridge back on, because it is the safest and it's most effective as well. So we've got dabigatran, also known as Pradaxa. So it's dependent on renal function. It's probably the least commonly used one. If at low bleeding risk, can be recommenced in 24 hours. But here I've just got like the high bleeding risk surgery and low bleeding risk. It also depends on how their kidney function's doing as well. And here we have apixaban and rivaroxaban, so that's your Eliquis and Xarelto. So also dependent on your renal function, so usually it can be recommenced within that 24 hours. So one thing that I've really noticed here in the orthopaedics ward is because they're not actually charted, they should really still be charting them when they're admitted and just writing that it needs to be withheld for whatever amount of time, because I find that the doctors might just forget about it. So if you guys know, or if you see it in the patient's drawer but it's not on the charts, maybe just flag it with the CMO as well. Yeah, commonly with aspirin I see it sometimes if they're on it for Eliquis and things, so just making sure that those patients are getting back onto those drugs as soon as possible. So now we're moving into antiplatelets here. So your aspirin, clopidogrel, ticagrelor, usually stopped around 5 to 7 days before surgery. The doctor will usually go through that with the patient over the phone or in person as well. So when to restart, usually it's recommended, the surgeon will talk to them about when to restart it, but pretty much it can restart as soon as surgery is done. So VTE prophylaxis post-surgery. So choice of agent depends on developing the risk of a VTE, and the risk of bleeding as well. So the factors that will determine the agent most appropriate is their VTE risk factors, which I've got on the next slide there. Bleeding risk factors, so if they've got other diseases, blood disorders, if they've had strokes or uncontrolled hypertension, or the consequences of bleeding as well. So their renal function, as we saw, will also depend on when they'll restart, what their doses will be, and why is it necessary. So just because patients have reduced mobility here in the hospital, they're at risk of blood pooling, so they're not doing their common normal exercises that they might be doing at home, laying in bed more here, reduces their mobility. Trauma to the blood vessels as well, so where they've had the surgery, they're at risk of forming a clot there. and changes in blood flow to the area. So factors affecting VTE prophylaxis. So these patients here are probably going to be at higher risk of a VTE. So your age, 60 or over. The weight will also affect it. Traumas or surgeries, which in this case will be the case. Prior VTEs, cancers, blood disorders, heart failure, lung disease, pretty much comorbidities as a whole. Then we've got your mechanical prophylaxis. I know a lot of patients in here tend to have stockings and things like that, so I just thought I'd include that as well. So these might be suitable for patients that can't actually use anticoagulants, so because their renal function might be really poor, these are a really good option as well. So they can be effective alone, or you can actually use them when using anticoagulants as well. So it should be avoided in patients that have conditions such as peripheral neuropathy or vascular diseases, because it is compressing those blood vessels. And we've also got graduated compression stockings should be worn until the patient is fully mobile again. So VTE prophylaxis in hip or knee replacements. So this is just specific to apixaban and rivaroxaban. So again, renal function is important before dosing. So it's usually dosed for apixaban at 2.5 milligrams twice a day, or Xarelto 10 milligrams daily. So they're pretty low doses in the scheme of things. So total hip replacements usually for 28 to 35 days, as well as using those stockings as well. And total knee replacements is shorter duration for 10 to 14 days. So what if a patient's already using these drugs? Yeah, so we're going to use it at that therapeutic dose that they were using for other conditions like atrial fibrillation. So aspirin, it's pretty much the last sort of line. So you'd be using your Xareltos and your Eliquises first, but this is for the patients that are at very low risk of VTEs. So this is patients that might be under 60 that have perfect renal function. Do not use aspirin for VTE prophylaxis for surgeries other than hip or knee replacements, as it's not as effective as anticoagulants. So it's usually at a very low dose as well, so 75 up to 150 milligrams a day. That's usually for 6 weeks. And then we've got Clexane, so that's pretty common here in the orthopaedics ward. So Clexane is first line because it's safest and most effective. Can be used in in renal function, as poor renal function as well. So it can be used as prophylaxis or therapeutically. So the dose is dependent on the renal function again, but usually most typically it's 40 milligrams a day. Unless the creatinine clearance is under 30 mils per minute, then it would require a dose adjustment and it would be 20 milligrams a day. Clexane is being used therapeutically. It will be weight dependent as well as dependent on the renal function. So it'll be 1 milligrams per kilogram twice a day. So that's how you'll know if it's being used therapeutically, is you'll usually see it morning and night. But it can also be used as 1 milligram per kilogram once a day if they've got reduced renal function again. So usually that's when you're seeing like your 60 to 80 milligram doses. And this is a common issue that I see in orthopaedic surgeries is the triple whammy. I don't know about you guys, but I got that drilled into me at uni. So the triple whammy is when you've got an ACE inhibitor or an AT2 blocker in combination with a diuretic. So that's things like furosemide or hydrochlorothiazide in combination with an NSAID. So most commonly, a lot of surgeries, particularly in this ward, they will go home on either Celebrex or meloxicam. So it's important, if you do see them taking something like rindapril and furosemide, to flag it first and say, are you really sure that you want to be getting this NSAID? Look, if it's completely necessary and they think that yes, it is appropriate for the patient, it should be used as short term as possible. So we don't really want them going home with a full box of 30 of NSAIDs if we can avoid it. Particularly in elderly patients with blood pressure agents. It can increase the risk of kidney injuries and renal failure. So particularly in our elderly patients, we're looking at we want to be looking at their renal function while they're in here, seeing, look, how clinically appropriate is it? If their renal function drops below 60 and you're noticing a trend that it's going down when you've got the NSAIDs on board, you'd be flagging that, saying, look, I'm noticing a decrease in their renal function. I think it could be something to do with, I mean, you can always ask the pharmacy team as well. We are there to sort of, you can chuck us out an idea and say, look, I think this patient might need a clinical review. We're happy to come and see the patients as well, and then we can speak to the doctors if you're not comfortable. And what should be done? So should be either ceased, or it should just be thrown as little as possible. I think with the NSAIDs, for me, it's, they're on them, they're on opioids, they're on paracetamol. Is this really appropriate? They've got all of these other things on board for pain management. I think that their kidney function is probably more important than a short-term NSAID, but if it's clinically necessary, yeah, we can just use it as short-term as possible and monitor the renal function. And that is everything, guys. Thank you for coming.
Thank you.